Dr. Ziubryte, and really great to have you here at the Euro PCR 2026. We have done this before, I believe last year, maybe the year before that. You have been a long-term user of the QFR and appreciate all the work. You have done very nice publications over the years. Can you give us a little bit of an insight, experience? Well, how do you see now that the QFR works in terms of ease of use, simplicity? How far are we with all the automation? Have we received the Red Dot Award also for the user interface? Can you say something about that?
Yes, definitely. First of all, thank you very much for having me here. It's my pleasure to be here every year. And talking about the ease, it's very easy because at first it took quite long time to achieve high quality analysis. And for now, with the latest version, we have at the best scenario less than 1 minute. And if we have some troubles with overlaps or tortuosity of the coronary arteries, it took 1, maximum 2 minutes to perform. And this really gives us answer very quickly, and we know what to do with our patients. So it really helps in our everyday clinical practice.
Fantastic. And that, of course, very important, the real results by the expert users. We can say we think that it can be done in a minute, but I mean, the evidence needs to come from you, from the users. Like you mentioned also already, you have been a long-time user of the QFR. You have seen all the steps that we have made and continue to make also to make it really simple in clinical practice. But what I want to talk about also with you is you had an abstract at the AIPCI recently in February, I believe.
Yes,
and I got here an abstract that shows the 5-year follow-up outcome of QFR versus FFR with really amazing results. And that was an abstract. You are working on the manuscript.
Yes, of course. We are doing our hard work on that. And we still miss some patients to reach 5 year. And the number of that in total, I think, will be more than 1,000 patients, and that will be really nice data.
Before we continue, can you, for those who will see this interview, give a summary of what the study is?
We analyzed data of patients who were admitted to our hospital from the end of the 2018. As we started to use QFR, we included all the patients who came into our hospital and were performed any kind of physiology assessment, QFR or FFR. So we included all these patients, data of these patients, and we are going for 5 years follow-up on those patients for MACE, deaths, and repeated PCIs in target vessel or any other vessels. So these data we will have next month, and I think it will be very interesting publication.
Yeah, and of course 5 years is an enormous, it's a long follow-up.
Yes.
What you showed also the differences in MACE.
There were no difference. In QFR and FFR, they were the same.
Yeah, so it's non-inferiority basically.
Non-inferiority. You need strong statistical analysis to prove that, but the data is really, really nice.
Yeah, as you know, we have done all the studies, we continue to do studies, but this is really independent evidence. I mean, you've done all the work by yourself. We have not been involved in that, so it's really
definitely
independent, a great amount of data, and the results are non-inferior between QFR and FFR, and that is also, as a company, of course, what we really need to get to collect all those evidences in addition to everything what we have already.
I think this study actually has the same thing as it strong thing and disadvantage. This is one single center study, but that means that the only user of QFR was done all these analysis. That was done by me, and I know how I did that, and there is no difference in all these analysis. So we can count on that. And if all our viewers remember, our results of QFR and FFR agreement in our center was excellent at the very beginning and from the very beginning.
Yeah,
So
yeah.
I'm really into QFR, and I wish we prove that it was not even non-inferiority, but it's superior to FFR, because we don't have any wires. Agents like adenosine, we do
Yeah.
not need that. So
Yeah.
it's really nice to have very useful and very easy to use tool on our table.
Yeah. And do you see that also spreading in your department for daily clinical practice? I mean, you are now the expert user, of course, but do you see that also, certainly once you have these data,
Yeah.
do you see that also your colleagues will...
Definitely. Every our colleague, maybe except 2 or 3 senior colleagues who are not very familiar with physiology in general, and of course in AI technologies, so they are so skeptic. But younger colleagues really love QFR, and they come to me asking how to do that, how to correct, and I'm
Yeah.
really happy that we're using QFR.
But I mean, it's very important, and of course, it's different whether you place a FFR wire into the patient or that you just do a software analysis. Basically, that's
Definitely.
a change of mind, and usually, like the younger doctors, like yourself and colleagues, they are maybe somewhat easier to move from one technology to the other. But that's also a matter of time, and the more evidence we show, will be easier also for your colleagues, all your colleagues, to really switch over from the wire to, say, to the non-invasive assessment.
Yes, absolutely. And what else we see in our clinic? We had a study. We analyzed patients with acute MI and with non-culprit lesions, comparing to FFR and IFR or just QFR. And there were no difference in outcomes. They are still beautiful data, and we use it in our everyday clinical
Okay.
practice.
Okay,
And
well,
that helps us to not implant stents where they are not needed.
yeah, no, absolutely. Well, I think you are doing an amazing job with
Yeah.
with your team, and maybe with other hospitals in the area, in the country, and we look forward to those results, and happy to help you also where possible, of course.
Thank you very much.
Greta,
It's-
thank you so much. It was
It's
a
my pleasure.
pleasure
Thank you.
again. Thank you.
Thank you.